la camicia così. Dobbiamo farlo in italiano.
Si può iniziare?
Bene. We start with the webinar. Good afternoon, everyone. We are gathered today for a new initiative of the Italian Society of Human Reproduction, and in particular of the special interest group working on international research project and social communication. It's really a great honor and great pleasure to welcome some of the most internationally recognized expert leaders in the world of human reproduction. From me and my colleague Caterina Ando, coordinators of the special interest group, and on behalf of SIRU, thank you all for being with us today. The program point the finger at some of the hottest topics that arise in the practice of IVF and which can have an impact on the outcome and health of the woman. The chances of pregnancy have increased in recent decades, also thanks to the improvement of drugs and ovarian stimulation protocols, but the various endocrine metabolic status determine different conditions of infertility which should not be treated in the same way. There are still many women, for example, low responders, and protocols that lead to an inadequate response with relative cancellation of the cycle, or in reverse, lead to the risk of ovarian hyperstimulation in patients, for example, with polycystic ovary syndrome. The webinar presentation and related discussion will aim to evaluate the best way to treat such a patient according to the quality versus quantity of oocytes and therefore of embryos, the primary purpose of ovarian stimulation. Finally, it will be taken into consideration how artificial intelligence can be useful in improving assisted procreation procedures, leading to better results in terms of pregnancy rates and healthy baby born. I don't want to take up too much time of the speaker. Just remember, if possible, to stay within 20 minutes scheduled with the possibility of 1 or 2 questions, or even to have a complete discussion, in particular the first 2 topics, because the speaker have to leave for previous commitment. Nevertheless, taking into account so the 2 speakers, and I think that I can introduce briefly Professor Marchi. You all know maybe Professor Marchi is actually at that time is fully professor in Obgyn in University of Ferrara. He's a specialist in obstetric gynecology, in gynecological endoscopy, in medical assisted procreation and treatment of endometriosis. He's working in Ferrara as a professor, and is working as a clinician and also a teacher in Geneva, in Clinique de Champel, non mi sbaglio, giusto? In Clinique de Champel, and also is a double phase, not only clinician, but also consultant for the programs in WHO, always in Geneva. So I think many more things I can use to describe Roberto Merci, but I don't want to take more time, and I let Professor Merci to have his topic, to discuss it with his topic, which is exactly the title is how to improve safety and efficacy of ovarian stimulation. Roberto, please, Professor.
Thank you very much, Piero. I'm going to put inside my presentation. Thank you very much for your nice presentation, and thanks so much to organize this nice webinar. It's always a great pleasure to be with you. You are always full of nice things that since a long time that we met the first time here in Switzerland. So I'm very happy to be here with all of you. And ladies and gentlemen, dear colleagues, and the topic is really interesting. As Piero told to you, the ovarian stimulation in assisted reproductive technologies is the crucial point of our results, is the important and crucial point, especially in terms of quality of the oocyte, on pregnancy rate. And we try to pass through all the points links to the ovarian stimulation just to see what is the best today and if we can really improve the safety and efficacy of the ovarian stimulation too. And as you know, I'm sorry, it's not going on. Okay, good. As you know, the growth of IVF in the last 40 years was incredible. Just looking the slides, you compare the last years between 1990 and 2005, and you can see that we have a great increase on number of cycles and in terms of the publication that we publish on PubMed, looking to the research in IVF too. And if you look to the story of the development of in vitro fertilization, we can see that today we are at least between 40 and 50% of pregnancy rate when we consider patients younger than 35 years old. So this is very interesting to see that the growing of the ovarian stimulation, the techniques, the laboratory, and everything is going to achieve the best result in this matter. And if you check to these slides, you see that today we have more than 10 million babies born after 1978 after the first baby that was born with in vitro fertilization. And if you look, it's important to know that today we have 3 countries like Japan, USA, and China too, that they perform 1 million of cycle per year. And if you look to Europe, Spain is one of the most active country, like France and Italy too. So it's very important to check to this data, because it's important to know how is going on the in vitro fertilization today. What we want exactly from ovarian stimulation, of course, that it is safe, efficient, and we have to look for sure to the cost benefits linked to the ovarian stimulation too. Recently, we have the new guidelines from ESHRE, and I'm going to pass through the ovarian stimulation just to see at the end what guidelines is going to suggest to us, what is the best practice that we should adopt or use in our ovarian stimulation. The ovarian stimulation is linked to is important because the ovarian response to the gonadotropin stimulation is really important for the success of in vitro fertilization. And today we have two possibilities. One is the count of the follicles before to start the ovarian stimulation, and biochemical field is like the dosage of level of AMH that is important just to decide the starting dose, to decide which kind of stimulation. So today is maybe is easier to go on with the ovarian stimulation, and is not really empiric like it was 25, 30 years ago. So the goal of the ovarian stimulation is to develop several mature follicles just to have good oocyte. And as everybody knows, that we have different medication like FSH, urinary recombinant at HMG, and then we can use agonists or antagonists to prevent the premature LH surge, and we can use different medical treatment to induce the triggering of final oocyte maturation. So it's very important this kind of treatment that we can use. And the important thing that we can avoid the risk of ovarian hyperstimulation syndrome, and we can avoid all potentially serious complications that can occur with the ovarian stimulation. As I told you, with the guidelines, we can exactly see and compare our attitude with linked to the ovarian stimulation with the ovarian response. Of course, what we have to know that is very important, the live birth rates, the safety of our stimulation, the patient compliance, and if it's the case to have the individualization of the cycles or not for our patient too. The idea of the ovarian stimulation is to produce a good number of sites of quality of course, and starting since 10 or 15 years ago, we start to discuss of the best number that we should have to retrieve for achieving the good results. And we stated that between 10, 15 outside of the quality, maybe you have the best pregnancy rate. When you start to pass 20, maybe the pregnancy rate is going to decrease because it's changing the quality of the oocyte. And what about the gonadotropin? Of course, we have to consider the type of gonadotropins that we can use, the starting dose that is very important because we have to decide for each patient what is the best. What is the starting dose? It should be for all patients the same, or if we have to choose one special dose for our patient, for some kind of special patient. The strategy for inhibiting the LH surge and the multiple ovulation triggering too. As you know, we pass through different years. If you are old like me and Piero, we pass through the 80, 90, and the fifth generation of gonadotropins. And of course, we arrive to a different kind of treatment. And all the time, we have papers, we have research, we have the different study that try to compare the efficacy of one with the other one. At the end, I will show you really briefly the results, because if you go through all Cochrane and randomized course study, you can see that at the end, the comparison of different gonadotropins is going to achieve to the same results. And we have no evidence effectively or statistically significant difference in live birth rate. So the clinical choice of the gonadotropin should be really dependent of availability, convenience, and cost. And that's why we should try to choose the best for our patient, also linked to the cost, to the efficacy of the treatment too. If you check to this article, it was recent, it's 4 years ago, that we compared the corticotropin alpha versus recombinant follicle stimulating hormone. And in this case, the meta-analysis is going to achieve exactly the same story with similar results. So you see, we have all and the contrary of all in the sense that sometimes we have some research paper that say, okay, is the best the recombinant, then is the best the other one. But if you go to compare everything, at the end, we have always the similar result in the simulation. And the same for the 5th generation. When you compare the folitropin delta for the IVF program, we discuss if the best is to have the individualization of treatment, the starting dose, but at the end, what you want to have is a good quality oocyte. We want to avoid the risk of ovarian hyperstimulation syndrome, and we want a good pregnancy rate. That's why it's difficult to say today what is the best treatment that we should choose. You should choose, because we really don't know what is the best, but we have, of course, to try to choose the best for our patients. And then the other debate, it was a long story since 20 years, if we should add the LH to FSH to ovarian stimulation. So we know that supplementing FSH with LH has been suggested to be a better mimic normal physiology. After that, the same, if you check in the literature, you see that we have all different results, in sense that in some reports it's better to add LH, in other one it say that it's not good to add the LH in ovarian stimulation. That's why if you look to the guidelines from ESHRE, the use of RFH with HMH for ovarian stimulation is equally recommended. So this is the first point, as I told you, that today we can recommend one on the other one, which not big difference in terms of results and in terms of quality of oocyte. And in the second point, we have the same, that the LH with FSH can have similar live birth rates compared with RFSH alone. That's why you see that at this moment, when we start 20 years ago to think that there was a beneficial effect in poor responders in advanced age, is not really true, because it was demonstrated the contrary, and it was demonstrated that we have no really difference at this moment too. So at this moment we have no difference, of course, but we have to try to optimize the treatment and our cycles, because we want to maximize the success. We want to avoid, as I told you, the iatrogenic risk like the hyperstimulation syndrome, and we want for sure to minimize the risk of cycle cancellation. You know that if you give a look to the dropout, that is very interesting. Most of our dropout in the IVF centers are linked to the physiological and physical burden of treatment. But if you give a look, we have also the dropout linked to the poor embryo quality or poor response linked to the senior ovariagic. That is, if you going to compare, is going to be between 14%. So in this case, we can state that our ovarian stimulation, the choice of the stimulation will be really, really important to avoid the dropout too. So what we have to do, we have a complexity, because we have to decide if we have to choose a treatment for one patient, or if we have to go for all patients in a similar way with the same starting dose. So what we do, usually when we have a patient, we check if she had already another stimulation, it was good. Maybe the clinician is likely to confirm the protocol as it was in the first attempt. It was not good, so if she had a low response or high response, maybe we are going to change the treatment. And if the no previous cycle has been performed, maybe the choice is like to the choice is like to be empirical, as I told you before. So what we have three kinds maybe of patients with we can classify as like poor responder, normal responder, and hyper responder. But what we have today, very important, is the possibility to check about the intrafollicle count that we can do with all instruments today in all IVF clinics. Is easy to do it. And the other thing is the dosage of the level of AMH. That is very important, just to decide what is the best stimulation for our patient. So what do we want? We want already to know the woman's age, the ovarian reserve, the body mass index, of course, the characteristic of the menstrual cycle, and decide in function of the oocyte of the PCO ovary or previous ovarian surgery, or if you had endometriosis or not, or other pathologies linked to the ovaries too. And with this parameter, maybe we can decide the best treatment for our patients. Starting from 2010, we had this nice paper that was published that's looking to the antral follicle count to the AMH, and we can decide if we expect to have high response or poor response. And I think today is still true, because when you consider the antral follicle count, the age of the patient, and the level of the AMH, in this case, you can expect a normal response, a nice response, or poor response, even if you can say, yes, it was empirical to decide, but today with this data, we can decide exactly how to stimulate our patients. So we can have a strategy for this starting dose. Here, again, we had many papers that is going to state that the starting dose should be 225, 150, and of course, in this moment, we can state that in the normal patients, the starting dose should be between 150 to 225 units. But in this case, with the simple models, you can decide exactly what you expect and which kind of protocol you should use, if you should use the agonist or the antagonist. You know, again, we have many papers that are going to describe different kind of papers. And at the start, we have many papers that describe the possibility to use the antagonist of a GnRH in PCO, and you will see after that that it was completely changed with the time, with the experience. So what's about the starting dose? For the ESHRE guidelines, we have the first choice treatment and the second choice treatment, and you see that in patients that we identify like low responder, the GnRH antagonist protocol and the agonist protocol are efficient too, with a starting dose, a dosage between 150 to 300 units per day. In the normal patient, maybe we can consider 150 and 225 units per day, with the best choice in antagonist protocol. And in the high responder patient, you can decide to stimulate with GnRH analog protocol with 150 units per day. So this is important because in this way, maybe we can decide already what is the best starting dose. But after that, if you look to this paper, it was 2019, the individualization of the dose not appear to improve the live birth, but the reduction of risk of hyperstimulation syndrome. So you see, at this moment, we talk a lot about individualization, but after that, in different papers, we say that we have no difference in live birth rate. That's true, but avoid the risk of ovarian hyperstimulation is important too. So I think that is very important when we have the elevated AMH and we have PCO ovaries. Maybe we should stay with the dosage of starting dose of 150 for sure, to avoid the risk of ovarian stimulation too. And this is the Cochrane is the same, is going to explain to us what is the best to predict the high responder. The lower doses of SSH should be better for our stimulation. So you see that today, now we know how to avoid the risk, and we have less and less case of ovarian hyperstimulation syndrome. So the personalization is important or not? Maybe is important, of course, when we decide to stimulate a patient. Always we start to think what is the best for our patient. After that, we know that the standard dose of should be 150 to 225, but we want for sure with good counseling, good anamnesis, and with the biochemical marker like AMH and the antral follicle count, we can decide what is the best, what is the most efficient treatment for our patient, and what is the best treatment to avoid the risk of ovarian stimulation syndrome. And if you go look again to recommendation from ESHRE guidelines, Other crucial important point is the adjustment increasing or decreasing the dose of gonadotropins during the treatment. You know that we studied many protocols with the step up, step down. We changed different way to our simulation in the last 20 years. At the end today, we can state that the changes are not really important today. Not really important because if you have a nice response, the delayed response to FSH dose change means that patient may continue the development of multiple small follicles, and the poor responder is not going to change the results in terms of number or site that you can retrieve. So at this point, the other crucial important point that we should discuss is this important to freeze all strategy provides an effective method to contain onto same dose of SH. So you have not to change because then at the end you can freeze all, or you can trigger the ovulation with agonist of generation to avoid the risk of the variant stimulation. After that, we have to discuss the pregnancy rate, the quality of site, whatever you want. And the same for the poor responder in this case, maybe it's not good to administrate the highest dose, but in some case you have to cancel the cycle, maybe to start again the treatment with a more elevated dosage in the second time. So the other point from the guidelines is a freeze-all strategy in case of risk of variant hyperstimulation. And we have in any case to check all the time for our patient the risk for high response, because in this case we know how to start correctly the stimulation. So again, what is the best, individualization or conventional ovarian stimulation? This is the good question, but I don't see, as I told you, the great difference, because every time we are going to stimulate, we are going to with the conventional, but is always individualized for our patient. So each patient is different from the other, and we know how to start the dose. This is again a study, the Optimist study. This is looking for our patients. It was more than 1,000 patients in IVF-ICSI treatment, and you see that in this case, again, the individualization is not good, but the standard dose is always the same. And the other point that it was stated in the guidelines, it was the protocol. And in the general IVF population, the GnRH antagonist protocol is recommended over the agonist protocol in normal patients, and in patient that is going to have the risk of the ovarian hyperstimulation. So at this moment, we have some point that we can state that what is the best protocol, what is the best dosage that we have to use. In conclusion, and I hope that it was in time, yes, it's 1 minute more, the main objective of the individualization of treatment in IVF is to offer every single woman the best treatment tailored to her own unique characteristic, and maximizing the chance of pregnancy, and to eliminate the risk of ovarian hyperstimulation syndrome. So the efficacy, efficiency, and safety means to arrive to have more oocyte, more babies, of course, and we have no benefit to add to change the dosage of stimulation. And what is really, really important is the safety of ovarian stimulation. Freeze all IVF cycle, reduce the risk of OHSS. So this is a most important, crucial point. Thank you very much for your attention.
Thank you, Roberto. Your excellent and complete talk. Should we make some question now, or you have more time to wait the following?
As I told you, I can stay still 40 until 6:15. I can be here for sure.
It's better that I give you a question directly.
Okay.
Roberto, in this case, you can go without any problem. Can I ask you something? Roberto, you hear me?
Yeah, yes.
Okay. But you have done very nice speech about this stimulation. You arrive at a very nice conclusion. means that we know now that all the gonadotropin are all the same. No any difference between the gonadotropin that we have been used 40 years ago and the new one with the recombinant that we are using now. There is also few different, just for few patients with a small group, when we add LH to the FSH, and also the element that we can use, that we have available to individualize a protocol, a dosage, a quantity of gonadotropin that we have to use for the patient, is they are very few. We cannot be satisfied just for the age, the MAH, the anthropological count. They show that they are not enough to individualize a person and go through the personalization protocol. Probably we need more. What do you think that we can start to? There is one example that we have until now. There is an algorithm that try to individualize a starting dose and use the weight of the women and the MHH. Even that is really not sufficient. Don't you think that the artificial intelligence can help in reality in a big way if we add other means element? For instance, the quantity, the weight, the muscle weight, the water weight, the kind of food that we use normally. If the women do some physical activity, if they have done some surgery, if they have suffer from some particular disease, I think that through the artificial intelligence, if we put all together these elements that we can take in the normal interview that we have with the patient, probably we can individualize better the protocol, the dosage. We can even give, I say, a previous idea about how many days can last the stimulation. We also can individualize, probably, if we have this idea more precise, personalized about the patient, how many oocytes we can recover. And really we can avoid the upstimulation or other thing. And probably we can give also something that we can say directly before that we start anything. We can see previously the percentage of pregnancy that these women can get by the in vitro fertilization. What do you think about, Roberto?
Grazie, Nino. Of course, as you know, I like artificial intelligence. Then I'm curious to listen the next presentation, the last presentation of today. But we can use algorithm, of course. But the food habit, always when you talk with your patient, you say to change the food habit for sure. Then if she's obese, you try to change the weight. You propose all the time to have physical activities. Of course, we can have something because we are going on for sure. So we are going better and better. But at this moment, what can change really the algorithm? Because the starting dose, of course, is between 150 and 225. I don't know if with all parameters that you can have from an algorithm, you can have a different choice, because the choice today with the experience, with the results that you have with the lab, with the quality of the oocyte, the pregnancy rate, and whatever you want is always between 150 and 225. Of course, we can do more. We have to go again to check something better because we have to individualize our stimulation for sure, but always we are always in the same direction. What we know today that we reduce a lot the risk of hyperstimulation. All is important to go on. Research is important, of course, and artificial intelligence could be important too. But I don't know if in the future we can have exactly something different, because you see, we're talking about ovarian stimulation since 40 years, and yes, we have more pregnancy rate, but the most of things we have done in the lab, and of course also with the quality of the oocyte. So it's important to try to check all details of the ovarian stimulation of the lab. Of course, the age of the patient is important too. We have many factors that we have to take in strict consideration just to achieve the best pregnancy rate. At the end, that's what we want for sure for our patient.
Yes, Roberto. But at the end of the day, now we are going to hear Sefrui that is going to talk about the upper stimulation with new tools. But at the end, the solution about the free zone is a solution that has come after, that we really do something different instead to avoid the up stimulation. Means that the female is already in up stimulation.
I ask you something. How many upper stimulation you have today? How many times you have to freeze all because you have the height response?
No, honestly, I don't like Roberto.
It's really rare. It's really rare. That's why. Yeah, you have maybe 1 a year. I don't know.
No, more than that. No, something that just is inside. When you think about freeze-all, would you prefer embryo freeze or oocytes freeze?
It's depend. Maybe embryo is better, of course. After that, it's depend how many oocytes you have. It's depend what your patient, what you do. Of course, the embryo is better for the quality.
Yeah, for the result.
Rate. Yeah, for the results, of course.
Okay, thank you very much, Roberto.
In any case, you remember, Roberto, when you publish also infertility sterility, your step up in polycystic ovary,
of course.
and you have a sort of paraphysiological stimulation. After that, and also the quality and fertilization rate was higher.
Yes.
I have the same results when I start to try my alternate day in IVF, and I have the same results with a low amount of gonadotropin, higher amount of quality, good quality, oocytes and embryo. Then after the result that we have to have more than 15 oocytes to have good results, more pregnancies, and are we sure that, and then also all the researcher on minimal stimulation, more physiological with good quality oocytes, are we sure that in young people, young women, even with PCOS, we need really to go with more of 15 oocytes and stimulate? Because I'm experiencing other laboratories now, more and more higher than 6,000, 8,000 picogram of estradiol. We never reached such a result, such a quantity of estradiol, more than 3,000, 4,000 maximum. We decrease our amount of gonadotropin. I think that, what do you think on that? Because
I think, Piero, that as you say, the experience is very, very important, because I still going on with the starting dose of 112 in case of PCO, in case of AMH, height AMH. So it's good thing that you say, because of course, if you look to the guidelines, they say, no, you have to start with 150. But when I start with 150, sometimes we have a really nice response. If you start, as you know, with 112, you have a more physiological response, good quality of oocyte, best pregnancy rate. So the experience can say to you that if you use a little less in your stimulation, maybe you achieve the best results. So this is a good observation for sure. Thank you, Piero.
Okay. Roberto, I think that you leave when you want. If you stay more,
I stay more with you. Thanks so much, Piero.
We are happy. And I would like to introduce our friend from Morocco, Omar Sefrioui. Omar Sefrioui is professor in Casablanca and professor of aesthetic gynecology. He's member. I have a very long CV, and I know a lot of activities of Omar, and is member of several aesthetic gynecology societies and of reading committees of medical journal, and he performed a lot of research projects. He is now president of the Moroccan Society of Reproductive Medicine, and present time is president of Mediterranean Society of Reproductive Medicine and director of ANFA Fertility Center, well recognized in Morocco and from abroad. I think we have a lot of things to say, but the time is terrible. I think we have to continue with the next topic, and we continue on the question of stimulation. And if we have, unfortunately, hyperstimulation or something in hyperresponder, how can we manage this condition before, during, and after?
Exactly.
Thank you. I let you the microphone.
Thank you, Professor Einaudi, and I would like to thank you and to thank all the SIRU board members to invite me and to give me this honor to be a part in this very interesting webinar. I know you do a lot of webinar, and SIRU is very active society, and I'm delighted to be one of your partners and one of your friends. And the scientific committee asks me to talk about the new tools in hyperresponders. It will be probably a continuum of the Professor Archie talked about just before me. And when we have to talk about hyper-response, we should know that till very recently, we didn't have any real consensus for definition. And we had different cutoff used from 14 to 21 oocytes. But anyway, we should keep in mind that we should put in balance the high pregnancy rate suggested by a high number of oocytes, and certainly the risk of complications, and especially the ovarian hyperstimulation syndrome. And we are very happy that we have, since very recently, since 2023, the HERA Delphi consensus definition of hyperresponders for IVF, and with a certain number of well-known experts. The purpose was to provide an agreed-upon definition of hyperresponse for women undergoing ovarian stimulation, and 17 of 18 statements reached consensus. And the most important one is the collection of more than 15 oocytes. But they considered that ovarian hyperstimulation is not relevant for the definition of hyperresponse if we collect more than 15 oocytes. And for the ovarian markers, the lowest cutoff was 18 for the antral follicular counts. And the lowest AMH was 2 nanogram, which in my opinion, a little bit low and we can consider probably a higher AMH, probably around 2.6 nanogram. Now, when we talk about hyperresponse, we should ask, why is it not desirable, how to predict it, and how to avoid it and to treat it. If we go to a mathematical logic, having more oocytes means we'll have more embryos. So it means we'll have more birth. So why hyperresponse is not really desirable? The response is probably in this data. Many of you knows this data, this famous data from Sunkara. And what did she conclude? That whatever the age, having more oocytes increase the live birth rate, but till 15 oocytes. Then what will we have? We'll have a plateau till 20 oocytes, but paradoxically, we'll have a decrease of live birth rate within fresh embryo transfer after 20 oocytes. This has been also concluded in these two nice data published in 2013 and 2016 by Dracopoulos, and they discovered, or they concluded, that fresh embryo transfer will have a lower birth rate after 16 oocytes, but the cumulative live birth rate was significantly higher with more than 16 oocytes. And from Dracopoulos, we have the same live birth rate between 10 and 15 oocytes, and cumulative live birth rate was much higher and significantly higher after 15 oocytes. Also, the used embryos is also important, and probably the most important thing within ART or an IVF cycle. And this data for about 265 women, less than 37 years, they compared the number of used embryos regarding the dose of FSH, and they concluded that they have more oocytes with higher dose of FSH, but they had lower fertilization rate and blastocysts, and also no more good blastocysts with the higher dose of FSH. But what is obvious is within this very interesting data for about 250,000 cycles in the US, more than 15 oocytes would probably make a higher risk of ovarian hyperstimulation syndrome, and this is something we all agree about it. Also, we have the risk of consolation, the transfer within the risk of ovarian hyperstimulation. The Gator in 2015, in a Swiss register from Switzerland, analyzed the number of consolation, and they concluded that more or less 18% of started cycle do not lead to an embryo transfer. This is more frequent if for poor responders less than 5 oocytes, and also for hyper responders when they have above of 19 oocytes, specifically for the risk of ovarian hyperstimulation. And also for the oocytes, for the oocyte number and the miscarriage rate. I have a problem with my laptop. Excuse me. This data from Sunkara also demonstrated that we have higher miscarriage rates when we have more than 4 oocytes, and also a higher miscarriage rate when we have more than 20 oocytes. And what about the outcome, the obstetrical outcome? We all know now that with hyperresponse directly related to the higher estradiol, we have more early preterm birth, and also low birth weight and very low birth weight with the fresh embryo transfer in patients with more than 19 oocytes, and this risk does not exist in patients with less than 4 oocytes, but higher risk than for patients with more than 19 or 20 oocytes. And the question, do we need more embryos to optimize IVF outcome? This data from Nargund from Copenhagen made a good conclusion, and she asked how many oocytes or embryo are needed to optimize the live birth rate per cycle. And the key message was for her 9 oocytes or 4 embryos optimized per cycle live birth rates in normal responders, having a fresh transfer in mild stimulation, IVF, and an optimum cumulative live birth rate can be achieved with mild stimulation yielding 12 oocytes or 9 embryos, whilst safeguarding against ovarian hyperstimulation syndrome. And this data illustrates perfectly what is the optimal number of oocytes regarding the safety and also the ART outcome. And we can consider that with between 10 and 15 oocytes should be the perfect response for a patient within ART. When we have less than 6 oocytes, we have less live birth rates and more miscarriage rates. And above 18 oocytes, we have also less births per fresh transfer, not per cumulative transfer. We have higher constellation, more ovarian hyperstimulation, and also some obstetrical outcome issues regarding the preterm birth and also the low weight and probably a higher cost. What will be the mechanism of deleterious mechanism in hyperresponse? Probably not for the oocytes and embryo quality, because it's uncertain and no data demonstrated that the problem or the issue was the oocytes and the embryo quality, but the issue should be probably the endometrium receptivity regarding a high progesterone cutoff, which is deleterious with the number of oocytes, and also the issue of placentation, which is estradiol rate in first trimester correlated and within the day of HCG, and the low birth weight with the obstetrical outcome. Now, how to predict hyperresponse? First, we need to identify the high-risk patients within the ovarian reserve markers, but also with some criteria. We know that patients with full criteria of PCOS are high risky for OHSS, and also isolated criteria like high AMH, but we need to consider the cutoff, the high antral follicular count, probably 18 should be a good cutoff, hyperandrogenism, response to previous stimulation, younger patients and low BMI patients. And we should also consider the patients of high risk of complication due to hyperresponse, which are patients with a history of hyperstimulation, of allergy, and also a history of thrombosis or thrombophilia markers. And for the ovarian markers, I think our friend Professor Archie already talked about it. And also today we can consider consensusly that AMH and antral follicular count as the most or the best predictors of excessive response in controlled ovarian hyperstimulation. This data from Anderson showed how deep is the relationship between AMH and antral follicular count regarding the number of collected oocytes. And this data had demonstrated a high sensitivity and also a very important negative predictive value, higher than 95%. Now, how to avoid and manage hyperresponse. And as Pieraldo, my friend, said, before starting, during stimulation, and after the pickup. So before starting the ART, we should consider probably the type of gonadotropin, not in terms of results or live birth rate, but in terms of number of oocytes. And if for poor responders, recombinant FSH is probably better in terms of number, because we can consider that with a recombinant FSH, the consensus says that we have 2.2 more oocytes with the recombinant FSH, and we can consider that we can have 2.2 less oocytes with hyperpurified HMG with a high level of evidence. And this data merit and Megaset, which all of you knows, demonstrated a low number of oocytes regarding HMG, but certainly lower risk of ovarian hyperstimulation. Even they consider a higher live birth rate, but we can consider that with the recombinant FSH, we have more 65 patients in this data, around 850 patients. So we can have 64 more pregnancy in cumulative live birth rates when we use recombinant FSH. So we can consider that cumulative live birth rate is probably better with recombinant FSH, where the safety is more in favor of high purified HMG. Now, before starting the ART, also we should think about the starting dose, and I think my friend already talked about it. And this famous data from Becker from the US, more than 650,000 cycles, they consider that in each group or each age group, a number of collected oocytes, we have a decrease of live birth rates from 10 to 20% with high dose of FSH compared to low doses when we analyze the good prognosis cycles, which means younger patients with no sign of ovarian insufficiency and endometriosis, neither ovulatory issue. And the high dose of FSH can be considered certainly as deleterious and not recommended, but they concluded that also minimal stimulation is certainly not recommended for this kind of patients. For the nomogram or the algorithm, we all know the algorithm of Lamarca, and Professor Archie also talked about it, and no data demonstrated any benefit in terms of live birth rate, but the data from Olivan and from Jovic demonstrated that when we use a consort calculator, we could have less than 12% of patients having more than 15 oocytes. But the most important thing is they have probably a very low rate of OHSS, around 0.3%. And though we can consider that these nomograms have probably no benefit in terms of ART outcomes, but it can certainly reduce the risk of ovarian hyperstimulation. But we can consider generally that for this kind of patients, starting dose should be around 100 to 150 international units for all risky patients. And sometimes we can consider starting at 75 units for patients PCOS with a history of ovarian hyperstimulation syndrome. Now, certain data consider reducing the risk of hyperstimulation in PCOS patients when we add when we adjunct the metformin regarding the hyperinsulinemia. And this data from Tso published in Cochrane in 2015, this one demonstrated that they had higher results in terms of live birth rates and lower risk of hyperstimulation of around 70%. But so the same author surprised us with another Cochrane in 2020, and he said that we had for antagonists, which is certainly the gold protocol for this kind of patients, he has a lower pregnancy rate, even lower ovarian hyperstimulation risk with metformin adjunct to FSH in antagonist protocol. Also, when we consider the protocol, I think actually it's obvious and no doubt about the antagonist protocol as the gold standard, especially with the last Cochrane from Al-Inani, who demonstrated that there was similar live birth rates, but certainly lower risk, less than 40% of ovarian hyperstimulation syndrome. And in another data, they consider 50% risk of OHSS with antagonists, and absolute decrease of 4% risk. So that means one OHSS for each 25 patients, and an absolute decrease of 10% of risk of OHSS in patients with PCOS. What about letrozole? The principle of giving letrozole added to FSH is that letrozole reduces the serum estradiol by inhibiting the aromatase enzyme and has growing clinical indications in fertility. The available evidence of letrozole's role in ovarian stimulation and clinical outcomes was assessed. This effect may have a good impact in reducing ovarian hyperstimulation, but unfortunately few studies analyze that issue on hyperstimulation. And that one from Bülow from Copenhagen, this meta-analysis demonstrated that there was no difference in terms of live birth rate and a lower or a tendency of lower risk, even not significant, of ovarian hyperstimulation. And her key message was that co-treatment with letrozole may benefit poor responders, but this is not our concern. Currently, evidence is insufficient to support a recommendation of co-treatment with letrozole in high responders, and further good quality studies are required. Now, preventing hyperstimulation within the stimulation, decreasing the dose of FSH, or the famous coasting. I think that this one can be forgotten, sorry, as the agonist protocol should not be used for this kind of patients, and as the antagonist protocol is certainly the gold standard. And that's why I ask, should we still use agonist protocol for hyper responders? And the mode of prevention should be taken probably at the triggering. And we have two modalities. First one is the reduction of HCG dose to 2,500 or 3,300, but there is fewer evidence to reduce the ovarian hyperstimulation risk, and we can certainly forget it. No difference between urinary and recombinant HCG, and the gold standard should be certainly the agonist triggering, because it displaces antagonists from receptor. It makes a flare-up for LH and FSH, and also the peak of LH is different because it's shorter and lower LH is released. And the shorter action than HCG gives us less or no HCG. We can use the three molecules, triptorelin, leporelin, or buserelin, but there is some terms of use to avoid the empty follicles. Certainly not a good recommendation for hypo because they don't have any FSH and LH. And it seems to have the same efficacy in PCOS or non-PCOS patients. And for some patients who had already a collection failure, we can consider these patients when they have less than 15 units of LH and a low progesterone 12 hours post-administration, and we can consider that it happens in around 5% of cycle, and the risk is certainly higher when LH is undetectable, especially for patients with long or irregular cycles or after taking pills for a long period. And this meta-analysis from USEF demonstrated that there is a low risk in population at risk of OHSS, but there is a less birth rate and lower results compared to the classic triggering with HCG. This is due probably to the issues in functional difference in steroid and angiogenesis in the granulosa, and also some modification of gene expression involved in implantation when it's compared to HCG. And how to rescue or how to repair this lower outcome in ART. We have two strategies. The first one is the freeze-all, which should already can be considered as the gold standard, or as what we call the luteal phase rescue, using a strong luteal support or a low dose of HCG, like Homaidan published few years ago. So when we compare these two strategies, Roque in 2015 in a randomized controlled trial compared the birth rate comparing fresh and frozen embryo transfer, and he found better results with a frozen embryo transfer and also lower miscarriage rate when he uses the freeze-all with the frozen embryo transfer compared to the fresh embryo transfer in hyper responders. And also the obstetrical outcome is to take into account about the cost effectiveness. It seems that there is no higher cost per birth, but it still needs to be validated. And for the child health, we can consider that both have some side effects. The fresh with the low birth and the preterm weight, and the frozen embryo transfer with the high or the very high birth weight or macrosomia with the frozen embryo transfer. But even with the freeze-all strategy, we should keep in mind regarding this analysis or the randomized trial from Greisinger that we cannot have, or we cannot reduce the risk to 0% even with the freeze-all, as in this data, he had 3 cases of moderate and 1 case of severe ovarian hyperstimulation, even with freeze-all strategy. The other solution or the other rescue is the luteal phase coasting, which is a new concept, and the principle is to supplement the luteal phase avoiding OHSS. And when we consider agonist triggering as a gold standard, the principle is to reduce the HCG to support to a minimal dose, depending of progesterone, dosed 2 days after the oocyte retrieval, because the luteolysis starts 48 hours post-ovarian oocyte retrieval, and the dose of 375 to 1500 units of HCG depending of progesterone, and they didn't find any significant difference in terms of rate, yes, or miscarriage rate, and also level of progesterone, even for low progesterone, less than 13 nanograms, and they concluded that low HCG dose less than 1500 units seems efficient to support low luteal phase after agonist triggering, reducing significantly the risk of moderate to severe ovarian hyperstimulation. However, risk of minimal and mild ovarian hyperstimulation is still possible. The other solution is a strong luteal phase support post-triggering, which is called the American technique. And the principle is to increase the progesterone and to add the estradiol with an adjustable dose of intramuscularly of progesterone daily, plus patch of estradiol in OHSS risky patients with agonist triggering till 10 weeks of amenorrhea. It seems giving good rates of ongoing pregnancy rates in a randomized controlled trial of 66 patients published by Engman. But more and larger randomized controlled trial are needed. And the strong luteal phase support seems to be a good option in certain cases for patients from abroad and for whom postponing embryo transfer seems high cost effective. Now, what about the prevention after doing transfer to reduce the risk of hyperstimulation? We can consider that cabergoline for 8 days is efficient after the meta-analysis of Letau in 2013. Aspirin from the first week is also efficient. Calcium infusion for 4 days after the oocyte retrieval reduced from 27 to 7% the risk of ovarian hyperstimulation. Also, adjunction of antagonists for 3 days reduces the risk of high or moderate ovarian hyperstimulation, but any randomized control trial has been published till now. But on the other hand, we can consider that there is no benefit or very low evidence of using letrozole or ketoconazole. And before concluding, we can consider this strategy of treatment for hyperresponders. We should, before programming, adapt the FSH dose and identify the patients with a risk of hyperresponse. We can consider adding or adjuncting metformin. We should adapt the dose of FSH, probably 100 to 150 units. And when we have more than 20 follicles or more than 4,000 picograms of estradiol, consider the generous agonist triggering as the gold standard. And then the freeze-all should be probably the gold standard strategy in terms of safety. But if we can consider any fresh transfer, we can make or consider luteal phase rescue, adding a low dose of HCG the night of oocyte retrieval, or a high dose of progesterone intramuscularly daily added with estradiol. But we, in any way or any risky patients, the freeze-all strategy should be the gold standard. So to conclude, the hyperresponders is a real issue in ART with high risk of OHSS. We should have a preliminary diagnosis and it's highly recommended, based probably on antral follicular counts and AMH. Antagonist protocol with low dose of FSH is the gold standard. High purified HMG can be considered regarding the low number of oocytes, and generous agonist triggering provides today the best safety guarantee and the gold standard. But if any risk even moderates, we must suspend the French transfer and direct to a freeze-all. And thank you for your attention.
Yes, thank you, Omar. Thank you very much for your excellent and complete talk. I think I was writing a few questions on my paper, but you have answered all my questions. So I think we have also only a few minutes because we have 2 more talk. Just a question, because how many embryo that remain frozen because young people become pregnant at the first cycle or the second cycle, and if you have a lot of oocyte, a lot of embryos, you risk to have a lot of embryos in your freeze. So why not make a distinction in between very high probability to be pregnant, or medium probability to be pregnant, or lower probability, and acting consequently? What do you think about?
I totally agree with you, and our embryologists are also have concerns about their full fridge, you know, and they ask probably to have less embryos. I am pro of the concepts we call the one and done. What is the one and done is with one attempt build a whole family. And I know in our Mediterranean area, in our country, for example, well, a mean of 2 to 3 children are more than enough. Actually, in Italy, certainly less, because I know the issues birth you have in Italy. But sometimes even when we lower the dose of FSH, we cannot through the super numerous embryos we have, because we are not sure which one of them will implant. For sure, the best strategy is to have more or less 4 to 5 blastocysts for each patient. But how many patients we can consider having the optimum of 4 to 5 blastocysts? When we have more, it's probably better, even if we can consider that we probably don't need for these young patients more than 4 or 5 blastocysts to build a family. That means to have at least 2 kids. But when we have more, it's not easy to throw this hyper numerous of embryos. But the worth issue, and when we have less, but this is another concern. I totally agree that we need an optimal dose to have at least 10 to 15 oocytes and to have 4 to 5 blastocysts. When we have these kind of patients, but it's more or less 40% of all the patients we have, and 60% of them have even a poor response or hyper response and are probably candidates for the freeze-all.
Yeah. I have no other question. If there are some questions,
No, just
one.
Piero, just one curiosity.
Yeah, very short.
Omar, yeah, short. Omar has done very nice talk, excellent, was complete, as you said before. Just one curiosity, Omar.
Ti ha posto la telecamera, ti si vede mezza testa.
Yes. Just if you in your experience, probably you noticed this or you didn't. Do you have any experience about a type of organotrophin or type of protocol and the influence with the embryo frozen? Means there is any connection, you didn't find any connection between the capacity of oocytes to be fertilized and go under freezing process when we calculate the cumulative pregnancy? Means there is any connection or any kind of protocol is the same, even in the final result of the cumulative result?
I understand your question, and honestly, we never find any difference in terms of ART outcome regarding the type of gonadotropin. Actually, we use 70% of our patients are under FSH plus LH. Considering, well, this is another debate, considering especially for hyper response patients, that having lower number of oocytes is probably safer for this kind of patients. But in terms of ART outcome, we really never saw any difference in terms of frozen embryo transfer and also oocytes freezing the results. And in my mind, there is no data that demonstrated any differences in terms of our ART outcome regarding the type of gonadotropin or the type of protocol, even antagonist or agonist. If I have something to say, for a very low category of patients that have a very high response, even with very low dose, I think we can consider for these patients using letrozole, starting with letrozole 1 pill for 2 or 3 days before starting the FSH recombinant or the HP-HMG. We are doing a randomized trial now. We have almost 65 patients, but we want to arrive to 120 patients. And the result seems very optimistic in terms of safety, and without having less competent and good blastocysts. So maybe we can consider that for this kind of patients, but there is a few categories. because most of the patients, PCOS, have normally a good response with 100 to 150 international units. And actually with the agonist triggering, we are very comfortable and with a very few risk of high or moderate hyperstimulation syndrome.
Thank
Okay,
you.
Omar.
Thank you very, very, very much. And I think to move to the next speakers, and but we talk on this topic in maybe in Bari when we met together in Bari, because it can be interesting for study protocol together. Okay.
Sure.
Now I welcome Professor Timur Gurgan and Dr. Cassuto. They are already with us. Good morning, good night, maybe, dear friends. And just a brief introduction, very, very brief, because our friend from Turkey, from Ankara, is a specialist in obstetric gynecology and endocrinology and infertility. He is in charge of, is full professor in 95, I'm right? In 1995, in charge of endocrinology in the infertility department for a long period of 10 years approximately. He was
Piero,
Oh.
you don't need to read anything. You know, I think we have to spare some time for the
because
presentation.
it's too long, but you were president of different societies. I mean, ESHRE, I mean, other society, Congress in Turkey, where we were present. And actually, he is scientific director of Gurgan Clinic in Ankara for women's health, infertility, in vitro fertilization, and so on. It should take a lot of time to present you. But
No,
I
thank
think that your presentation will spoke about you more than more. He is also involved in some project for artificial intelligence, or I'm wrong? Yes.
Yes.
So we have after Dr. Cassuto with artificial intelligence. So this is maybe a good section. Okay. I let you the microphone, Timur.
Okay, thank you very much, because, you know, I'm very proud that I'm with you. We are the friends. We have been working in several societies, several places, and it's nice to be with our friends from, you know, Italian society. So it's our really privilege to be with you all the time. I think, you know, Professor Omar was just is going to invite you to be in Marrakesh. He forgotten it, you know, because he's the chairman of the International Society of IVF, and we will be having a very big and very good quality meeting in Marrakesh next starting in next November. So, and it is going to be my lecture. I'm not going to go to the very details, but I understood that from the previous, you know, speakers, they were just talking about how we are going to make the ovarian stimulation for the normal responders, but usually we go for the hyper responders. But when we are just talking about the oocyte quality or the oocyte fertility or the fertility by the sperm, we are just putting everything in a same basket. The main headache for us is just when we are just talking about the ovarian stimulation, we have to get some information about the patient woman, what we are just concerning with. Because at the end of the day, usually we are using nearly the same protocols, and we are just talking about the FSH or HMG or whatever and the dosages. But at the end of the day, we are just thinking about the quality of the egg. We don't know, because Omar was just saying that, okay, hyper responders is okay, but if the embryos are developed for the day 5 or day 3, and with the good morphology, and we could put them in and they could get the pregnant. But it's not only the genetic of the embryo developed from the special, let's say, the particular egg. So at the end of the day, we have to look for the chromosomal aneuploidy rate. But it is depend upon the what we are giving, what is the, the age of the patient and the infertility time, whatever. So when we put the embryos in, usually if we have the good quality of the blastocyst, and especially after the, genetic testing, if we put something like 3 cycles of the good quality, genetically normal embryos into the endometrium, we could get up to 70 or 80% of the pregnancy. So the important thing is just what we are having. So we know that, okay, it's not the high quality of the gametes and the embryos, it is also very important for the endometrial receptivity, because we know that it's not only the aneuploidy rate, but also the cytoplasmic incompetence of the egg is very important to develop the right embryos, which could produce the pregnancy. Maybe Omar is right, because if we are having, let's say, 10 embryos in our hand with the good morphology, we don't know how many of them is going to produce the pregnancy and the healthy baby. And there is something from the literature is saying not every oocyte can develop the embryos which could give the, the pregnancy and the healthy baby. So how we are going to do it? Because now I think after that, Doctor is is going to talk just about the, the artificial intelligence, and we put them into the computer. Computer can tell us the blastocyst is going to be the right blastocyst, is going to produce the baby or not, after informing or putting every information about the, the patients into the computer, and at the end of the, the blastocyst formation, we could say something is going to be okay or not. So after talking that, I will be just going, I don't know if my computer is just, the slides are coming, okay. So I will be talking to you not only the hyper responders, and we know that even if they are the normal responders or the hyper responders, at the end, we cannot get the good quality embryos. The embryos quality is not good enough, even if in the hyper responders. We know that in the PCO patients, there are some problem of the egg quality, embryo development. So how we are going to increase their quality and the pregnancy competence. So we know that I will be going very quick. I know that the time is just not too much for us. So, and I have to move a little bit to the different side, because for the poor responders, because in the poor responders, we could get some eggs. It is not too much, so we could say that, something like not more than 3 or 4 eggs. After fertilization, we could have the embryos, but we know that the embryo aneuploidy rate is just very high. So we cannot get the pregnancy, higher pregnancy rates. And also, even if we get the pregnancy, the abortion rate is high. So the question in our mind is just what are we going to do? How are we going to support the intra-ovarian system to produce the better follicles and the maybe better eggs at the end to be fertilized and to produce the, competent embryos. So we know that it's not only the central nervous systems or the hypophysis, FSH and LH can have the major effect. Yes, they have the major effect, and they have the effect on the or in the ovaries and on the follicles. There are lots of things are happening intra-ovarian environment. If the question is, can we improve the intra-ovarian environment to produce the better oocyte quality, not maybe the numbers. So I will be just reviewing what is going on. So it's not only, we know that the age is very big headache for the ladies after the 40, after the 42. So we know that the pregnancy rate is going down. So the cytoplasmic competence and also the aneuploidy rate is just going up and the competence is going down and the risk of the abnormality is just going up. So at the end, we cannot, even if we have some oocytes or the embryos, without doing any kind of genetic testing, we cannot get the pregnancy. Even if we get the pregnancy, the abortion rate is high because the aneuploidy rate is going to go up to 70, 80%. So what are we going to do? So we know that in there are lots of questions, including the follicular pool and mainly ovarian dysfunction of the ovarian follicle genesis and the others, and some surgery, endometriosis, and the PID could be the just responsible for that. We have several rejuvenization modalities. It's not maybe the wrong word, talking the rejuvenization, but I think it's better to use the support of the ovaries. If we could improve the quality of the follicular genesis, and at the end we could improve the quality of the egg. So there are something that I have to warn you. What I'm going to tell from now on is not the really things that we could talk to the patients without informing them what is going on. If we don't select the right patients to do the right things, it is going to be the not good good practice. So we have to tell them something, and we have to add something real value. So we don't want to improve or increase the great expectation. So because it will come to great disappointments. We have some modalities. So I will go from now on in vitro modalities, in vitro oogenesis, in vitro activation. So we are very far from the generation of the human organelle from induced pluripotent stem cells, which could be used commonly for everybody. We are very far away. So everybody is talking for nowadays for the patients, saying that, oh, we are using stem cells. Stem cells is not that we are using, because not the stem cells should be stem cells to be used and to induce the human organelle from the mature cells. Nobody is just doing and using it. So I'm going to tell you something different way. So we could make some ovarian activations. So maybe you heard about that, the disruption of the hyposignaling. So what is the hyposignaling? because this is something that we could in vitro activation of the follicles and the autotransplantation and the hyposignaling. Hyposignaling is just something the problematic in the ovaries, and which could stop the activation of the folliculogenesis, which may be functional for some patients, because it is something going on for the mainly. I'm not going to tell it could be used for the poor, let's say the menopausal state, even if the patients are just very young. So, but it could be used especially for the diminished ovarian reserve. So in this kind, so there are the system, maybe you could see from this slide that we could stop the folliculogenesis, we call it the hyposignaling in the ovaries, and we could disrupt this hyposignaling system with some activators or the physical force. So after this, using these systems, so we could increase these some molecules, some secretions, or that name that the EAP test, whatever, for the nucleus, and we could activate the follicular growth and increasing some factors, which is just a hyposignaling system to deactivate it. So what are we going to? It is the first, publication came from the Kawamura years ago. So we mainly, when we make a kind of the cortical removal for those patients, and we could activate the ovarian follicles for the infertility treatment. So what is just doing is for some the menopausal state patients, they could get the oophorectomy and the cryopreservation after this taking them out, and they could make a kind of cortical mincing, and also they activate these cortical pieces in the 2 days culture, and after that they make the second laparoscopy and to autotransplantate this cortex into the ovaries and back. But this is something, and they use the activators, but we could do for some different techniques for the diminished ovarian reserve, because they use the first one for the menopausal state patients, but we could use this system for the diminished ovarian reserve without using the activators. We could take the cortex partially and fragmented them, and immediately return and transplant into the ovarian cortex, under the ovarian cortex back. It is just one surgery. Okay, what is just doing it? So I can, maybe you could see this video. So, and we did, so you could see this system, and we could make it's not moving anyway, so, and you could see the ovarian cortex, just put it out, give it to the embryologist, they just make a kind of cutting here. And after that, we could, you see that, we mince them and put it this some, we produced a new system, the catheters, and put them in. After we put this cortex into the ovaries back. We may be using that, we use the menial laparotomy for these cases, but we may be using this system for with the laparoscopically as well. So after injecting this cortex back to the ovaries, and we follow up them. So what happened was just we could have some data. We couldn't publish it because of some regulatory problems in Turkey, but we could tell you that for the diminished ovarian reserve, we could produce the folliculogenesis. Maybe in the severe cases, we could get the oocyte retrieval nearly 50% of the cases, and we could have the oocyte and to oocyte and the embryo transfers, and we could have something like the 20 and 30% of the pregnancy. So there were some publications in the literature, and we could say that the drug-free in vitro activation of the follicles and the fresh tissue autotransplantation as a therapeutic option in patients with primary ovarian insufficiency. But we are just not saying this because I think this is the indication for those cases is doing it with laparoscopy with some diminished ovarian reserve, and we could get really good quality eggs when we are using it, and we could increase the pregnancy rates. Another one is the platelet-rich plasma. So I don't want to go too much because we could use the platelet activations, and we could using this one into the ovaries, the plasma, and we could increase the follicles from the ovarian stem cells, development of the differentiation of the uncommitted ovarian stem cell into the de novo oocyte, or we could awaken the latent oocytes, or supporting the development of the existing premarital follicles and small secondary periantral follicles, or reactivating the follicular growth through the restoring microenvironment of the ovaries. We have just lots of data that especially the dense granules can have some various cytokines, growth factors, and some molecules which increase the folliculogenesis and increase the chemotaxis, cell divisions and migration, and cell differentiation. So immune modulation. So at the end of the day, and when we use the PRP, but with a special centrifugation protocols, I think this is used for the ovarian system, and we could have the really follicular activation, preantral increasing the preantral follicles, cortex volume, angiogenesis. At the end, we could increase the good quality oocyte, even if we don't increase the system, increase the numbers. So, and we could increase the pregnancy. So we have been using, and nearly we have more than 300 cases. So we could have different system. We could use the concentrated growth factors and doing the different 3 times centrifugation, and not only increasing the platelet activation and also to increasing the growth factors. So we have the video, what we are doing it, and we have the PRP, and we use the general anesthesia, and with this egg collection needle, so we could go into the ovaries and make the injections just beneath the cortex. So we could inject nearly, you see, 2 milliliters of the PRP to the both ovaries. It is just not very difficult injection. So at the end, so we could finish it something like 3 minutes time. After that, we follow up them something like 15 days to 1 month. After that, we use the FSH to increase the follicular spermatogenesis. And there are lots of publications in the literature. They use it for some menopausal states. So we are not just suggesting you to use it for the menopausal stage cases, but in our hand, if it would be better to use for the poor responders, and you could increase the quality, possibly the quantity of the oocyte, and you could get the better pregnancy rates. So, and there are something in our study, and we could use it, and we could get really good with our diminished ovarian reserve. So I can tell you something, and we have maybe it is the first in the literature. So we start to use the PRP for the PCO patients. So for our data, this is the first one for the recurrent IVF failure in the PCO cases. So if there's 0 pregnancy after 2 or more recurrent IVF failure in the PCO cases, and those are the clomiphene resistance cases. So when we use the PRP, we could get up to 50% of the pregnancy. It is just very interesting. So we are just thinking that injecting the PRP subcortically, which may be very helpful, possibly through the hyposignaling disruption system, which may be functional for the PCO, disrupt the hypo system, and after that, the ovulation starts. So, and I can tell you something, it is the feature, maybe you heard about the extracellular vesicles, which are the exosomes. This is something very new, and we started to use it for some diminished ovarian reserve cases and also the PCO cases. So we will maybe make a kind of presentation in Marrakesh, because we know that the exosomes are just very important for the follicular development and the good development of the oocyte in the follicles. So when we are just using the exosomes from some resources, so we could increase the growth of the Gronza cells, oocyte maturation, follicular development, ovulation, fertilization, and we all know that it is just important to exosomes can have a kind of involvement for the premature ovarian failure, PCO cases, endometriosis, and also some kind of ovarian cancers. So, and there is only one publication in the literature saying that the exosomes as a biochemical agents in the diagnosis and treatment of the polycystic ovarian cases. So in our hand now, the exosomes are derived from the placental stem cells isolated by ultracentrifuge, and it came to us prepared, and we started to use it for the PCO cases and diminished ovarian reserve. So from now on, I'm going to use only 3 minutes to say that if we could have something from some cells from the stem cells, and stem cells, source of stem cells nowadays, especially we could get it from various places, but just there are few publications, and the bone marrow derived stem cells has been used to stimulate the ovaries, which is stem cells of the ovaries. So, and this is the ASCO study, and we know that the BMDSCs, bone marrow derived stem cells, can be used for the diminished ovarian reserves and the premature ovarian failure cases to increase the local ovarian vascularization, increase the follicular and stromal cell proliferation, and reduce the apoptosis. there are only few studies in the literature using this ASCOS approach, and ovarian function improved nearly 80% of the cases of the 17 premature ovarian problematic patients, and they could have the production of the pregnancy, but it should be again to be used with the different centers. And there are several systems, but I don't want to go to the details, because after getting these cells from from the blood with a special apheresis, and you could get these stem cells, or you could get it from the iliac crest aspiration, and after that you could put them into the ovarian vessels, or direct the intraovarian injections. There are only very few applications maybe they could come, which is very much complicated to be used for everybody. Lastly, and we could use the mitochondria to be injected or to be used for as an energy of the ovary, and we know that this is something with the aging or with the decreased ovarian capability of the producing the follicles, and they have already low levels of mitochondrial DNA and decreased ATP production, and increased ROS, and which could be getting with in several ways for the poor embryo quality and failed implantation. So there are some few cases in the mitochondrial enrichment of the patients. There are some complications, but it is a headache if you are using different technologies, especially if you are using some heterologous system, which could be used some cases is cytoplasm of the donors, total cytoplasm transfers, spindle transfers, whatever. But now some autologous approach, which is named as the argument, there are only 3 publications in the literature, and last one was Labarta in 2019, using the autologous germline mitochondrial energy transfers, and we could use the immature oocyte in vitro activation of the dormant primordial follicles, in vitro maturated immature oocytes, or the self-grown cell mitochondrial transfer, non-ovarian stem cell mitochondrial transfers, maybe synthetic mitochondria is coming for the gene addition. So, but we need to further some new clinical trials to be, push them to be used for the treatment for everybody. So I can tell you that there are current treatment options far from the providing realistic solutions, and I can tell you that PRP is widely has been used, but it should be used not for the postmenopausal patients in our hand, and our, let's say, the experience is just saying this, and we could use maybe in the PRP surgical activation, and for the future, I think that the exosome treatment can be useful for some group of patients. Thank you very much.
Thank you, Timur. As usual, you are a real pioneer, and you show us new frontiers all the time. But you have also the courage and the strength to go through. You started with in vitro maturation, and now you talk about stem cells and so on. So thank you for giving us an idea of what could be our approach for infertility during.
Yes, there was some, saying that from the USA, that, and there would be all the time the dormant stem cells left in the, even if they are in the menopausal state, but just we don't know how to activate them now. I think, it is possible because stem cells are everywhere, but sometimes we don't know how to manipulate them properly. Another important thing is just even if we could manipulate them, at the end, we don't know if they are just capable enough to produce the pregnancy, or they could produce the healthy baby. But the question is just coming, the menopause can be postponed or menopause can be overcome. If this is another story. Now in our hand that it is possible, we may be using now the oocyte freezing, or something like maybe we could be using the some ovarian cortex freezing. So we could, even if we don't want the baby, and we could use this stored cortex.
But that one, that one is another.
Yeah, but in my mind, menopause is the menopause. There is no, just now, in my knowledge, and the people are working in USA, if we could do something, but today, I don't want to give any information or optimistic approach. It is
right.
my.
You still think that we have a reserve?
Yes.
Okay.
Ladies have all the time the reserves.
Just the reserve. They go to by the time they were consumed.
Just
okay.
Before, because if they live something like 120 years with the gene editings or to prolong the life expectancy, they may start the ovulation back again.
Okay.
So we have to be optimistic. Thank you very much. So I think Dr. is just going to tell us if we use the let's say the system, artificial intelligence, to put every information in, the artificial intelligence tell us if it's coming or not. So we will listen.
Just a brief question, Timur. Concerning the PRP, you use for rejuvenation and so on, but concerning the endometrium, with insufficient endometrium, repeated implantation failure, etc., if you prefer, or you have better results in injecting the PRP subendometrial or into the uterus, simply?
I have a system, maybe it is easy. We are using this subendometrial injection.
Yeah.
So I can tell you that it is just something is new, and we are using some needle going into the catheters, and we see the subendometrial system, because that the basal lamina is there to activate the stem cells. Yeah, but for the endometrial things, and we have another things in our hand to using some cells, culture cells, and after that the PBMC, maybe you heard about that. So, and the important thing to get the pregnancy, you have to use not only the egg quality and the embryo quality, we
But
have
also
to be for the endometrium.
the endometrium quality. Yeah,
Yes.
for sure. But
Yeah.
I have my idea is that to put the PRP simply into the cavity is not correct, is not sufficient.
Yeah, but because this is something, I don't think I have I didn't bring it because I have a videos just
Yeah.
when we go inside, even
Mhm.
if you could make the injection and you could see that the PRP is just going just through the subendometrially. So it could be stimulation. So anyway, we have to discuss it in different lectures because
Yeah.
this is something people are just putting inside. The another important thing is just we have to see something using the injury model for some cases.
Yeah.
And yeah, but when you are using it, you have to use the hysteroscopy and you have to use some fluid inside, even if you inject it and it goes out. So, yeah, but I think that in some cases, because Antonis is just talking all the time
Yeah,
about
yeah.
repeated implantation failure, but people are saying that if you have a for a good quality blastocyst, you don't have to take care of the endometrium. I don't believe that.
No.
Because this is the ESHRE recommendation. Make the blastocyst okay. If you could find out the blastocyst to be good enough to make the embryo transfer, it is okay. But sometimes we don't have the too much blastocyst to be, injected.
Yeah, for sure.
Yeah, thank you.
Okay, thank you. If no other question, I think, thank you, Timur. Stay with us if you can. And we move to the next speaker, and last but not least, Dr. Nino Cassuto is with us. Hello, how are you?
Yes, I'm fine.
I know
I'm
you.
fine. I hope that my connection's still good because it's unstable.
Is unstable.
Hope.
So we hope that we become more stable than before. So just a few words. Just Nino Cassuto is one of the key opinion leaders in his field in andrology, and he works in Paris, even if he's in Tel Aviv now. But he works in Paris. He manages and is responsible of at least 3 laboratory in the hospital in Paris, in different hospital in Paris for IVF, and he manage also other laboratories. And he is deeply involved in research to better have instruments and diagnostical materials to have more powerful power in diagnostic of infertility and to get more powerful our techniques in laboratory of IVF. Artificial intelligence is one of the gold standard for him, and I think he will have something very interesting to show us and to speak about.
Thank you.
It's your...
Thank you very much for introduction. Thank you, Pieraldo. Thank you, Nino, everyone. And hope that you have the connection now. You have the slide.
Yeah, it's perfect.
And you see
Yes.
me or no? No?
It's good.
Yes?
We see you and we hear you.
Perfect. Okay. Now we are talking for the sperm. We have a lot of communication today with oocyte stimulation, woman, but the sperm, never people talk of the sperm. The sperm, I don't know, because perhaps it's for the more little cells in the body. Nobody take care for the sperm. And I think it's very, very important point, actually, when you have a lot of failure in IVF or in ICSI. And the possible role of artificial intelligence in IVF is like that. When we see a picture, the same picture with different person, and we have a different perception, we have a different integration of this picture, and then we return a different drawing. It means that this is a problem of the subjectivity decision. Subjectivity is influenced by personal feeling, opinion, moods, or taste. With artificial intelligence, we cancel this subjective factor. What's AI technology? AI is an overarching system, a global system that can learn quickly and apply huge data to solve and to work in many fields, particularly in the medical area. All around us, we have a lot and more AI application, a lot of startup, also in IVF and in unit labs to take a decision. How does it work? Artificial intelligence include different technology, such as machine learning and deep learning. Machine learning is a subset of AI. Computer learn from data to make prediction and take a decision without programming. Deep learning, yes?
I'm sorry, we didn't see any image. Have you launched your slide or?
No, you have this image?
You are always your funny face, but no images.
Must go out. You have something?
You have to push the green button in the lower part of
I know. This is. You have it now?
Yeah, it's okay.
Yes?
Yeah.
Okay.
No, it's okay, Nino.
Okay, Nino. Okay. We can go like that? Yes?
Yes,
Okay.
yes,
Perfect.
right.
Bravo. Perfetto.
Now, have you seen the first slide, this one? No?
You start
No.
from the beginning if you
Just
want.
what I see, just when you see a picture with the same picture, we have a different perception, a different integration, and we return a different drawing. It means that it's a subjective decision. With artificial intelligence, we cancel these subject factors. What is now AI technology? Is an overarching system, a global system that can learn quickly and apply huge data to solve and to work in many fields, particularly in the medical area. All around us, we have a lot of AI application today, and we have a lot of startup on IVF. And how does it work? Artificial intelligence includes different technologies such as machine learning and deep learning. Machine learning is a subset of AI. Computer learn from the data to make prediction and take decision without programming. And the deep learning is a subfield of the machine learning. And using artificial neural network, making up the backbone of learning algorithm in fashion that it can make accurate decision by itself. Now, we can easily understand that this contribution of this technology in our IVF unit, and more particularly in IVF lab, it's very important. And we have more and more future improving IVF succeed of that. And the first example is for the embryo selection. Sure, we have different classification according to the morphogenetic of the embryo on the tree, and also the classification on the blastocyst on the 5 with Gardner classification. But we have a very different decision. If we have all the data stored and used for detection non-operator dependent, it means that if we compare the optical decision for the embryologist on optic microscope and AI contribution, there is no doubt that the more information with AI and the more accurate the choice, it means that we are going to select the best one on very quick and fast time. Now, if we compare the two decisions in a lab for the embryo selection by AI and AI for sperm selection, it's absolutely different. It means for the embryo, we're dealing with a final goal. We can do nothing to change the results because we have the blastocyst in our petri dish, and we cannot change any evolution on this blastocyst. And if we don't transfer the good one, we're going to keep another one in our tank in nitrogen liquid. And now with the vitrification, we have the same results with after thawed, this embryo frozen by vitrification, we have the same result than in transfer, in fresh transfer. For the sperm, it's absolutely different because in ICSI, when you are choosing the sperm, I am just talking for ICSI. Now, when choosing the sperm, it's a crucial step because you are just on the beginning of the fertilization process. And it depends on the DNA quality of the sperm. And if we inject a bad DNA quality, a bad epigenetic profile of the sperm, we don't have any results, any early embryo development. Now, when you see that more and more in the labs, we are doing more and more ICSI and less IVF. We are choosing the sperm, and have you seen it's very little cells. Now, when you see a sperm like that in a microscope, also in high magnification, you see the different sperm, how it's move, how it's look, and we don't know what's happening inside. We don't have any information what it's carry on for the DNA quality and for its epigenetic profile. This is why the problem is in one ejaculate, we have different sperm head morphology, the worst to the good one. And all the sperm have the same genetic information on a double helix DNA sequence, but they have different epigenetic information according to the methylation profile on the 5-methylcytosine. And according to this different chromatin methylation profile, we have different outcome. It means different fertilization rate, different blastocyst rate, or not blastocyst rate, different results in outcome, miscarriage, and birthday, and sometimes with birth defect. Now, the story starts many years ago when you published this classification This classification was published not only visually. We saw the sperm at high magnification, and we inject in very good oocytes. Like that, we avoid female problem, and we take young oocytes to look what's happened with different kind of sperm. And we make a photo, and after we see which sperm give us a blastocyst. And you can see on the last column here, you have some kind of sperm. We never reach a blastocyst expanded on day 5. And we classify this sperm from the score 0, which is the worst, to the score 6, which is the good one, to give a blastocyst, and 0, never. And we decide to classify this sperm at high magnification because you have a more precise morphology and we can appreciate little details. We thought at the beginning, perhaps that we can find a link because, like I said, we have the morphology, and if we want to go ahead, we need to find a link. We need to find a biomarker. You need to find something that you can tell us with this morphology, what is carrying on inside on the quality DNA. We thought about the chromosome status. Unfortunately, we don't find any connection. We look for the DNA fragmentation, and for some study, I agree that we can find a correlation. But you see, the more important is for the chromatin. And this, there is a consensus. It means when you have some kind of sperm morphology at high magnification in score 0, you have a bad connection. You have a bad transformation, histone and protamine. And if this connection, this condensation is not tightly, it's not strong, it's not good, the genome pattern, it's open and it's weak against oxidative reaction. Now, we saw also, if we select the sperm differently, we can have better succeed on the measure, on the birthday, on the birth, because we saw if we're looking at the sperm at low magnification and we don't select the level of, on the profile of the methylation, we have more birth defect. And this, it was a little systematic review and meta-analysis published in 21 and presented in Vienna. It confirmed this selection of sperm. It's very important on the consequence of the birth defect. Now, we are going deeper to understand what we can find, this link always. We found there is a difference on the methylation level between the 0 and the 6. And more recently, we found there is also a difference on the level of genes expression. We select, it was a lot of work, we select between the 22,000 genes we have on the genome by system and with a gene ontology, we select 10 genes, and we found a different level of methylation. And if there is more methylated genes, we have less mRNA present on the sperm. And you are going to look at the level of this mRNA by PCR. And we found a big difference in the score 0 and the score 6. And these genes are working together in a network with different nodes, but communicate with them. This to prove the last thing, that we have very different population with different profile, epigenetic profile. This was presented just this last SRM in New Orleans, that also for the microRNA profile is different in the score 0 and the score 6. Now, all these papers confirm the presence of different sperm epigenetic profile in the same ejaculate. And which tool today is more appropriate and more accurate than the AI to sort, to identify, and to select them between millions? When you see, for example, in PubMed, you see during the 5 or 10 last year, we have more than 6,000 papers and different articles concerning the sperm selection. But if you are looking for AI and sperm selection, only 60, but in last 2 years. With very interesting work looking for the goal and what you are doing with AI and sperm selection. We decide with all these results to start to build a new algorithm with AI. We take a data because, you know, AI need huge data. It's hungry giant. We give 800 hours of video. It's mean more than 3 months in continued vision. And this data was sorted in 15,000 frames, randomly captured, and then arranged by biologist expert, labeling and classified, presented visually to the machine learning, deep learning, and teach the machine to do the job. Now, how it works? You can see on this video the sperm moving on the screen. There is communication between the microscope and the computer, and the AI is doing everything, organize everything. First, there is a control panel of the system, and you can see on this part in gray, this is the different code for each action managing by the AI. You can put again, you see there is different point. The first is to detect, identify the spermatozoon at high magnification according to the AI algorithm that we teach the machine between other cells and artifacts. After, there is a tracking. It gives one unique number you can see on the screen for each spermatozoa, and they follow it. And to keep it on the center of the platform, if the spermatozoon is swimming in one way, the computer with the AI make on the platform of the microscope the inverse way on the same speed to keep it on the center. After this detection and tracking, the computer classified all the spermatozoon according all the information, the data that we give it. And it's mean that it classified according to the score, to the speed, to the morphology, with a template for the size, the shape, and it's going so fast because it can capture 30 frames per second. It means that any brain, any person can do it the same and to analyze and to go back to the data that you have in the computer. And after that, it tag. In red, the bad one. In yellow, is waiting for the decision, AI. And if become yellow, become after in green, he move the platform to another pipette is waiting. The pipette move down and waiting. There is no sperm around, free of spermatozoon. Like that, there is a pump aspirated and put it in a clean droplet for use it in ICSI. This is all the system and the machine. Now the prototype will be ready, I think so, in 2 months, but it was a lot of work, algorithm time to organize all the things. And now for the data, because actually we don't have clinical data because prototype is not ready yet. But because you are mimic exactly what you are doing every day in our labs, we don't change the media, we don't change the optic, we don't have laser, we don't have nothing new. It just mimic the system by working, not us, but the computer and AI. I found these papers published on 21, explain that the fertilization rate is novel indicator for cumulative live births, and the study was for more than 9,000 cycles. What I do? I take all the results that we have in the health authority of our center, and you can see that this is the center results, this is the mean of the results, and this is the median and minimum and maximum. And you can see this in red. This is our fertilization rate, 81%, versus for the mean of the country in France, in ICSI, 61. We have more than 25% more fertilization rate. And we are no donors. It means that we don't have very good result. You can repair some sperm abnormality. And if you go in another center, the same, 83, 61, 62. And 10% more for pregnancy rate. And if you go in another years, the same result. It means we have more than 1,000 and 1,000, perhaps million oocytes injected by this method. And this is the result, always the same. This, in conclusion, this selection sperm according different algorithm, according to different gene expression, according to the different microRNA profile, epigenetic profile, is selected the better. I don't say the best of the one, but the good spermatozoa to get better pregnancy rate. And this system, because it's autonomous selection without operator dependent, according this DNA quality, using AI combined with micro robotic. Thank you. This is what I can say today for this new system that you are developing.
Thank you very much, Nino. There are some questions. Timur or Nino again. I have the impression after your talk, both from Timur and you, that in not a brief really time, but in few years that are coming, our techniques, our labs in IVF will maybe change in a substantial way, because all the instruments or new techniques can change, and we will have better results, but without the intervention of the specialist, of the laboratory specialist. Do you think that, or you think that the role of the embryologist will be always essential?
Yes, I think so. It is a question that is said in my lab. All the embryologists working said, if you are doing that, what we are doing with our job.
Yeah, yeah,
No,
for
no,
sure.
no, no. I think it's something help us to do better, to do faster. But you need human intervention. You need embryologists. First,
Yeah.
to go in the machine, to analyze the results, to... No, I heard that people are working for to make a system for automatic injection. This is another
Yeah.
step.
My question was provocative, obviously. I think that such an instrument can reduce the variability in between embryologists, or when you inject more than X oocyte, the error increase, while with the machine, maybe if the machine can also take a part of the job of the embryologist,
Exactly.
and can
Because
help
it's
to reduce the errors and to increase the quality.
error, perhaps it's too strong, but we have the machine is going always the same work, standardized,
Exactly.
according to the data, according to the algorithm, and
Exactly.
there is no subjective decision.
Exactly.
Piero, can I?
Yeah, please. You are the discussant.
The official one.
Yeah.
It's just something simple, Nino. What do you mean when you say micro robotic that is connected with the artificial intelligence? What is the micro robotic? The other thing that is about your opinion, you think this process that you are applying can, I say, take the place of the natural process of selection? Means that in the nature, or even in the IVF, the normal IVF, there is a natural selection for the spermatozoa and get in. With this process, you think that we can recover this ability that the nature has when selects the spermatozoa that get into the oocytes?
No, no. For the robotic, the system of the micro robotic is just for the pipette is coming down, waiting for the sperm, moving the platform, and when the sperm tag in green is waiting, and after the robotic is to aspirate it and put it in a new clean droplet of media.
Oh, right. This is
Doing
not a manual, the embryologist work.
no,
It's a machine.
no, it's a
It's
machine. But after you must to take the sperm from this
dish.
droplet and to dish and to
Right.
inject and to inject all the injection and the do for in the oocytes. It's still the same. It's just
Right.
before for the robotic. But I don't think so that the system that you are doing now will be better and stronger from with the natural, with the IVF. This is, I said at the beginning, this is just for ICSI, because with the system, we've programmed for 20 sperm selection, no more, because we don't need more in a cohort. It's maximum 20, 25. There is a PCO, we can make a double research of sperm. But this is the machine do it in 10 minutes for this selection, and always with very strict criteria.
Please, Timur, you have a question.
Yeah, but this system is not only for the embryology. So we are just using a system balancing concept. In some way, we have to put together all of the information, not only from the embryology side, also we have to connect the clinicians and also laboratory information together. Because, you know, when you are using the system, you know, at the end of the, you know, picture, when it goes to the artificial intelligence and they could, the intelligence is saying that this is a good one or it's not a good one. It is giving the a kind of probability information. But it is not enough because what you put in, what you get out. We have to put lots of information for the couples and also the individually from the male and female side. And we are just saying that, and we have 6 steps to be given into the artificial intelligence system. The first one, as the Dr. Casuto said, that this is the information from the sperm side. But when we are just talking for the sperm, and it is a count, it is a motility, it is a morphology, or even if in the DNA content, those are different. And also we have some information coming from the very low sperm count. And if some people is just coming from the TESE cases, and also we are just using the ROSI injection and got the pregnancies. This is, it needs the information to given to the artificial intelligence. And also the second place is the oocyte, what we are using for the stimulation and what we are getting out, what are the, you know, the clinical side of the endometriosis, PCO, and the whatever. And the third one is the embryo quality. And also we have to think about the genetics, and we have to think about the endometrium. So every information should be inside and to be giving the data. And this is something that we have to balance everything. If we think something is not good enough, I congratulate the andrology side, but it is not enough. So the important thing is, at the end of the day, we are having the blastocyst, but if the scoring is not good enough, we have to come back and to see what we are doing. And sometimes the result of the different cycles are not the same. So I think it's a very long work, but we have to use in the clinical side, embryology side, and for the everything in the artificial intelligence. But we have some way to go, because
Today,
we have some way to go. Otherwise, and we could jump into the technology. And I'm saying that artificial intelligence, we need the intelligence artificial, but we all the time need the organic intelligence for the future, which are the human brain.
yes, but we cannot now today with the system to put information for the oocytes for the clinical part. This is after, when the machine is working, after the prototype, we are going to go to the final goal, to the pregnancy rate. But you cannot put on the system for the sperm selection the oocyte quality or the endometrium quality. It's not interfere on the sperm choice. It's absolutely different things. It's after. But for the sperm, it's not moving, it's not changing according to the endometrium. It's not moving according to the oocytes. But we need to find after the outcome of this spermatozoon selected by this system, by this machine. And this, I don't have the results.
I completely agree with you. This is a part of the sperm side. Yes, but the pregnancy is not coming only from the sperm, and also.
But I don't say that this machine is for to. I just talk for the sperm, and this is, I said, to look if this sperm outcome of the sperm selection with this machine is going to have better fertilization rate, better blastocyst rate, better pregnancy rate. But this study, clinical study, I don't have it today. I just can say,
Dr. Kusutos, you did the best thing because we started to use the system for the sperm, and we have some meeting all the time, but I realized that you did really very big a step forward. So it is not an easy thing because we have to start at the beginning. It is the sperm. Yes.
yes, and the sperm, it's at the beginning of all the system of the fertilization or the early embryo development. And we prove in another study with the gene expression that we are selecting sperm with different level of gene expression according to specific genes involve the early embryo development. But this we need to have after.
Yeah, but I agree with you because this is the missing part of the IVF and the ICSI, because we think that select the one sperm, put it in, and it is over. So this is very, very important part, and you open a door, and I think that it's going to be very valuable information from now on, and embryologists and IVF labs should be more careful for the selection of the sperm. You don't have too much things, yeah.
This issue.
Yes. Thank you.
Okay.
Thank you.
In my simple opinion, I think that is such an approach is already a very, very good step in improving our quality of the lab. This is one of the critical point to choose the good spermatozoa. So I think this is a good sperm, and maybe all the other variable point or step will be in the next few years, maybe Timur or other people or teams of people that can work together to improve all the process of the IVF procedure. So if there are no other questions, I think we have expired our time available. We can therefore close this webinar and I would like to invite you all at the SIRU National Congress in April in Bari, organized by the Italian Society of Reproduction. And thanking again the speakers for their brilliant and stimulating participation, and all the connected participants. We invite you to follow the activities of the group and maybe of the special interest group, and to participate in the activity of the Italian Society. Thank you very much. And last but not least, I would like to thank also our supporter, which is Ferring Pharmaceutical, which is always with us for every activity. And we are very, very grateful to them to support our webinars in details and our activity in the Congress. So thank you very much, and see you soon.
Thank you. Bye.
Maybe. Okay.
See you in Bari.
Bye-bye.
Yes.
Send us some information. We haven't got any information about Bari one in April.
You haven't?
No, because
So,
it is our place. Is our Dr. Tomato, and we like to eat some good fish back.
we looked that with the secretary and with Nino. Okay.
Okay.
Yes.
Okay.
Nino.
Thank you. Bye-bye.
Bye-bye.
Good night, everybody. Everyone.
Thank you very much.
Bye.
Oh, thank you to you. Ciao.
Ciao.